hope everyone can listen to me.
Yes.
Yeah.
Please proceed.
Right. So I'm Shreya, one of the co-trainees from England. So today I'm going to, sorry, let me remove this slide as well. Today I'm going to discuss about a very interesting case which I encountered when I was working at the Frimley Park Hospital in England. And that is about an ectopic breast malignancy. To begin with, ectopic breast tissues are found in only 2 to 6% of women, and those are most commonly found in the axilla and least in the vulva. They bear the same physiological and pathological variations affecting the normal breast tissue. Among those, only less than 1%, that is 0.3%, are malignancies. To begin with my patient, so this is a 78-year-old lady who is pretty fit and well, visited her doctor because she saw a slowly growing lump in the right groin for the last 2 weeks. So the doctor, after seeing her, scheduled some routine scans and bloods. However, she represented within a month due to similar lumps in the vulva this time. She had a hysterectomy done 20 years ago with preserved ovaries and was on hormone replacement therapy. She did not have any risk factors for development of breast cancer, like, as we all know, early menarche, late menopause, fewer number of pregnancies, or even having OCPs for a longer time or smoking. So because her history was a bit weird with development of lumps so often, she was referred us to the surgeons. We examined her. We found there's a single non-tender lump in the right groin, which was free from the underlying structures and the overlying skin. She did not have any other skin changes as well. On top of that, we found multiple lumps in the vulva lateral to the clitoris. So, what did we do for our patient? Firstly, as we should all do, we did an ultrasound scan of the right groin, which showed features of malignant lymph nodes. So we took a biopsy which showed metastatic adenocarcinoma of breast origin. Immunohistochemistry showed it was positive for CEA, ER, PR, but negative for HER2 and PAX8. Now, this was significant and important because we all know for breast cancers, ER and PR and HER2 are positive, but it's negative for PAX8, which is important for gynecological malignancies. And CEA was a marker for colonic malignancy. Now, this rose some confusion. To clear it out, we did a triple assessment to rule out breast cancers, and the mammographies were all clear. There was no lump noted in the mammography. Then we did a CT scan of the abdomen and pelvis. This picked up a right inguinal lymphadenopathy. I don't know if you can see my pointer or not, but in the right side of the scan, we can see a lump, which is the lymph node. Next, to see the vulval region prominently, we did an MRI of the pelvis. The MRI picked up again the right inguinal lymphadenopathy with possible vulval malignancies. So I have picked up 3 images which most prominently can show the lump and the lymph node in the scans. Next, we did the biopsy from the vulval tissue. This showed pieces of adipose tissue with heavy infiltration by high-grade tumor and foci of cibriform morphology and comedonecrosis. Cibriform morphology and comedonecrosis are typical for breast malignancies. Again, immunohistochemistry showed it was positive for cytokeratin 7, ER, and PR. Since it was all pointing towards a metastatic disease, we did a PET scan, and the PET scan showed metastatic right inguinal lymph nodes. Rest of the body was all clear. So, during these scans, we had multiple gynecological and breast MDTs to rule out primary breast malignancy. So we did a mammogram, which was all clear. We even did an evaluation under anesthesia, or the EUA, to look for the rectum, and a sigmoidoscopy because the because the immunohistochemistry was positive for CEA as well. And all of these three were negative. So with the scan and immunohistochemistry, we came to the conclusion that this is an ectopic breast malignancy. Why ectopic? Because the breast itself was clear. However, we found similar tissues in the vulva and the lymph node. Hence, this was an ectopic breast malignancy, which is extremely rare, less than 1%. We did a wide local excision of the vulvar lesion. We did a chemotherapy with cisplatin and a brachytherapy for the vulvar lesion. We had a follow-up. I followed her up personally for 6 months, and she was all fit and well without any signs of recurrence. Now, why is this case important? As in worth presenting to everyone, all the surgeons and dentists all over the world. So ectopic breast cancer was first described in 1861, and since then, fewer than 200 cases have been reported in the literature, which affects, again, mostly the axilla. There is still no definite treatment plan for ectopic breast cancer due to the very low number of cases. Some literatures prefers mastectomy, whereas others have shown similar outcome without any surgery on the breast. Histological similarities between ectopic breast tissue and benign adnexal gynecological tumors makes the diagnosis very difficult. And as mentioned earlier, only the immunohistochemistry can differentiate that. So breast cancer is positive for cytokeratin 7, GATA, ER, PR, and HER2, whereas gynecological cancers are positive for PAX8, apart from being ER and PR positive. Hence, this case makes a rare diagnosis of primary ectopic breast malignancy of vulva with good outcome, with only wide local excision of the lump itself. I would like to take the opportunity to thank my consultant, Ms. Isabella Carrot, who is a consultant breast surgeon, Dr. Maria Bahadahado, who was a consultant histopathologist who made me understand about the slides and the immunohistochemistry, and of course my two registrars, Georgette and Gautam, who introduced me to the patient. Now, these are all the references which I have noted down, based upon which I did my study. So these all. And so I hence end my presentation here. Thank you everyone for this opportunity. And if anyone has any questions, do let me know.